Good afternoon. This is Dr. Benjamin Domb from the American Hip Institute, presenting today at the American Academy of Orthopaedic Surgeons on management of the labrum. My disclosures are listed with the American Academy of Orthopaedic Surgeons. In this talk, we'll discuss the importance of the labrum, non-surgical measures, when to operate, labral reconstruction, labral repair, and some case examples. Over the last couple of decades, we've come to understand the anatomy and purpose of the labrum in much more depth. The labrum increases hip stability by increasing the articular surface by 22% and the acetabular volume by 33%. It has a sealing effect, creating a negative pressure environment within the hip joint and maintaining the articular fluid film. And it prevents lateral displacement and distraction forces while playing a role in load bearing, all of which leads to a chondral protective role for the labrum. Labral pathology can arise from a number of different elements, including cam and pincer type impingement, dysplasia, and activities. And all of these things can synergize to create labral pathology or labral tears. In an athlete with FAI, the combination of structural abnormalities, repetitive motions, and trauma can synergize to create a labral tear in an athlete like this NFL player here. Our initial approach to a labral tear involves 3 months or more of conservative treatment, which may include rest, activity modification, physical therapy, pain medications, plus minus intra-articular injections. And in the athlete, we generally must consider if they do need surgery, whether to perform it in the off-season versus in the in-season. In-season is if symptoms and their response to conservative measures have not allowed them to complete the season. But in the off-season, we have more time for recovery, which may tilt us toward operating in the off-season when surgery is needed. Of course, that needs to be tailored to the individual goals and risk-benefit analysis for the specific athlete. We know that restoring the suction seal matters, and this video here was created by one of our former fellows, Dr. Maldonado, demonstrating the importance of the seal and the ability to restore the seal here with a reconstruction, but one way or the other with repair or reconstruction. Labral repair improves resistance to distraction by 92%, and reconstruction similarly improved resistance to distraction by 66%. We've published the algorithm previously for approach to the labrum, and this algorithm suggested that for the repairable labrum, we should repair it. For the irreparable labrum, we have a number of options. For a segmental defect with a preserved chondrolabral junction, we may indicate them for segmental labral augmentation. With a compromised chondrolabral junction, they may be indicated for segmental labral reconstruction. And with a complete defect, circumferential labral reconstruction can be indicated. We've been through many iterations of surgical repairs, all of which have had the common aim of restoring the seal of the femoral head within the acetabulum. The latest iteration has been the controlled tension anatomic technique, and this modern technique allows us to achieve consistent seal of the labrum against the femoral head, taking advantage of inserter out selective tensioning technology for the repair stitches. The knotless tensionable anchor technology allows for selective tensioning, achieving a consistent seal, avoiding eversion of the labrum, saves surgical time, avoids the risk of knot loosening, and maintains a low profile of the suture. With a word of caution that the labrum can be everted with too much tension, whether using knots or knotless technology. Therefore, the controlled tension anatomic technique is critical to maintain that position. In terms of labral reconstruction and when to take the leap, at present, our indications in the primary setting have included insufficient labral tissue, segmental loss, a calcified labrum, severe labral intrasubstance damage, and in the revision setting, failed previous debridement or failed repair. The knotless pull-through technique, as we have previously published from American Hip Institute, has given us a safe and reproducible and very efficient way of producing a labral reconstruction, whether segmental or circumferential. And in terms of avoiding the knots, why not? The problems with knots are time, deformation of the labrum, potential for abrasion against the cartilage, the potential as a nidus for scar tissue, and of course, it requires skill. And we can circumvent our own learning curves to a degree by performing knotless labral repair or reconstruction. Here you see in an early stage repair from 15 years ago, the knot can act as a nidus for scar and can also cause eversion of the labrum away from the femoral head. So this I would call a suboptimal repair. In the revision setting, here we can see there are previous knots and significant scar tissue around those knots. All of that tissue has the potential for irritation and abrasion. There you see the knot within that nidus of scar tissue. Here, after we've removed the knot and once we've removed the scar tissue and the knot, we're left with no functional labrum, and this puts us in a position for labral reconstruction. So we go knotless to allow adjustable tension and avoid knot loosening. Again, a faster, simple, reproducible procedure, and it saves your fingers. An important part of the knotless pull-through technique has been to avoid the need for measuring. In earlier techniques for labral reconstruction, we measured the length of the defect and then created a graft which was tailored to that length. However, any error in the length of the graft, whether a little too long or a little too short, would make for a suboptimal reconstruction. Therefore, the leap forward of not having to measure until after the reconstruction is complete allows us to get a perfect length every time. This technique, the knotless pull-through technique, is applicable for segmental reconstruction or circumferential reconstruction. This begins with the diagnostic arthroscopy and debridement of the previous labrum, in this case, a previous repair, followed by decortication of the acetabular rim. And we'll decorticate with a beveled rim technique, which creates a bevel at approximately 60 degrees, which creates a biomechanical advantage for the graft as it seals against the femoral head. We then place knotless tensionable anchors circumferentially around the rim in the entirety of the prepared area. In this case, this is a circumferential reconstruction. They're placed from anterior to posterior using at least 3 different portals for the placement. We then thread the repair limb of the suture from the most anterior anchor behind the ripstop of the graft and pull the graft from the mid-anterior to the posterior lateral portal. This is what allows us to achieve the perfect length every time. In this video, you'll see that the graft is introduced through the anterior portal and then brought out the posterior lateral portal. So we have a very long graft, close to 30 centimeters, much longer than we'll need for the reconstruction. We pull it through the joint and then achieve the refixation of the graft in place. On the left side, you can see we're docking the anterior aspect of the graft to the most anterior anchor. And then on the right side, you see that we sequentially pass and cinch each of the anchors around the graft, passing and cinching from anterior to posterior until we've completed the reconstruction. Obviously, it's important not to lose track of the order of the sutures and the anchors. In a large reconstruction that is circumferential, we may have up to 12 anchors. Each anchor has 3 sutures, a repair stitch, and 2 ends of the shuttle stitch. So that can be 36 sutures and a graft all in the small space of the joint at the same time. So in order to keep track of our sutures, we'll clamp them in order from each of the anchors so that we maintain good suture management. Finally, after we've secured all of the anchors, we'll amputate and remove the excess graft, and this will leave a perfectly sized graft every time. This is the completed graft here. You can see this is a circumferential labral reconstruction, and you see it there posteriorly all the way to the posterior transverse acetabular ligament and anteriorly all the way to the anterior attachment of the transverse acetabular ligament. When we take traction off, the femoral head will return within the acetabulum and we'll look for a good seal of the graft against the femoral head. Fortunately, we have not had many opportunities for second looks after reconstructions, but we have had a few. And I must say I've been quite impressed with the body's ability to incorporate the labral graft at the chondrolabral transition and also the anterior and posterior anastomoses between native tissue and graft. In terms of outcomes, we have found that we've been able to achieve outcomes as good as with repairable labra using the knotless pull-through technique for labral reconstruction. So while we still strive to repair the labrum when it is repairable, in the case of the irreparable labrum, we are able to achieve outcomes as good as the repairable labra using this technique. In terms of the athletic population, 2-year follow-up has shown excellent patient-reported outcomes and a high rate of return to sport. So we do have time for a couple of case examples. The first is a 23-year-old female professional soccer player with left hip pain for 5 years, intensified in the last 3 months, positive impingement tests and Faber sign, and a Baton's of 4. So this is an interesting case because this patient clearly has significant impingement, but also has ligamentous laxity. So perhaps a component of FAI and a component of instability. MR arthrogram demonstrates an anterior labral tear and anterior superior labral tear. And at diagnostic arthroscopy, we can see that the chondrolabral junction does have a very significant wave sign with early delamination, but the substance of the labrum is preserved. So in this case, we perform a labral repair using the controlled tension anatomic technique. And as you see in the right-hand picture, when we take tension off, traction off of the hip, there is a good seal of the labrum against the femoral head. In the second case, we have a 28-year-old professional NFL player with 2 years of worsening hip pain and stiffness and unable to play for 4 months. On examination, again, positive impingement tests and pain with internal rotation. The X-rays here demonstrate retroversion of the acetabulum and cam-type impingement. So our diagnosis here is FAI with the labral tear, and we can consider next imaging, including MRI, MRA, or degenerate MRI, CT scan. Obviously, he needs to undergo rehab, perhaps an injection, and if all that fails, perhaps surgery. So in this case, he underwent a degenerate MRI, rehab, and an injection. The MRI demonstrated a labral tear, but fortunately, the cartilage was well preserved, so he is a candidate for joint preservation. After 8 weeks of no relief with physical therapy and only temporary relief with an intra-articular injection, he was still in pain. And therefore, we consider subsequent options, including more injections, therapy, biologic injections, or an arthroscopy. And the patient, through a shared decision-making process, landed on a hip arthroscopy. Diagnostic arthroscopy revealed a very badly torn and partially calcified labrum. So this, in my view, is a labrum that is irreparable. It is damaged beyond repair. And therefore, when we consider our treatment options, debridement or attempt to repair or reconstruct, segmental versus circumferential, in this case, I felt that the labrum was diseased circumferentially, and therefore we undertook a circumferential labral reconstruction, the outcome of which you see here, and of course addressed the femoroacetabular impingement by correcting his FAI. Returning to our algorithm for labral management, for the repairable labrum, we would advocate at this time for a repair. For the irreparable labrum, we have a number of options, including segmental augmentation, segmental reconstruction, or circumferential reconstruction. The segmental augmentation for a segmental defect with a preserved chondrolabral junction, the segmental reconstruction for a compromised chondrolabral junction, and circumferential reconstruction for a complete defect or disease of the entire circumference of the labrum. So in summary, Atlas told Zeus, I ask not for lighter burdens, but for broader shoulders. The armamentarium of techniques that we've described in this talk gives us those broader shoulders. These are complex techniques, but using advanced technology and these techniques we've discussed here, we can have a number of arrows in our quiver, including labral repair, labral reconstruction, both segmental and circumferential, and labral augmentation. Choose your cases wisely, consider additional training. It can always benefit us. I thank you very much, and greetings from Chicago.